So, what are the most essential and cost-effective technology that every doctor can use in their day-to-day practice?
The number one use of technology in diabetes, I will probably recommend in monitoring glucose, because that is the most important procedure or step which will 100% result in better control of diabetes.
10% of the patients they must be using even a glucometer in our day-to-day practice.
It is not 10%, it is not even 2%. Using glucose meters.
Exactly, that's what it is.
Dr. Ashwin David has been optimistic because in your practice, I know it is more than 90%. But overall in India, it is not even 2%. The reason is glucometers could be painful and it is cumbersome, and that is where the connected glucose meters can make a difference.
So what is the importance of continuous glucose monitoring in the day-to-day practice?
I think this is very important. In technology and in modern medicine, the beauty is it is dynamic.
Welcome to the D-Genius podcast. Today we are going to discuss on the topic connected glucose meters and glucose sensing technology in diabetes management. And to speak on that and to give us more insights, we have got the chairman of Jothydev Diabetes Research Centers, Dr. Jothydev Kesavadev. He is my mentor and teacher. He is always known as the technology man of India because he has been using technology for a long time in his day-to-day practice. Sir is the National President of Diabetes Technology Trust of India and has done a numerous number of papers on technology. So let's start today's talk with a discussion with Jothydev, sir.
Thank you very much, Dr. Ashwin David. I am very proud that I am very happy and delighted that you are interviewing me.
Thank you, sir. So, sir, as we all know, the technology before the use of technology, earlier we used to use urine, the Benedict's test to look for for testing glucose. Then came the blood test. Then came the HbA1c. Then came the glycemic variability. And now we have moved to after the glycemic variability, we have started using continuous glucose monitoring devices. And now a lot of glucose sensing technology are being available in the market, and it's coming up in day-to-day basis basically. So, do you think technologies are required for diabetes management?
This is a very common question. Whether we require an expensive technology for managing diabetes or not. Since you are having so many new drugs, we have so many new very expensive drugs such as GLP-1, Refosens. But if you look at the landscape and if you look at the outcomes in diabetes, it has not improved. And I might say that it has even worsened in people developing retinopathy or nephropathy or cardiovascular disease, where all the evidences, I will say that all the evidence has been generated over the last more than 20 years. I should say 20 years because in the last 2 decades there were more rapid advancements in technology. And it has shown that if you are using technology along with the existing drugs, then there is an unprecedented improvement in the glucose control. Not only in the glucose, in multiple other parameters. And every new drug, you may prove that the A1C reduction is 0.3% or 0.5% yes, or 1% sometimes. Sometimes. But when you are using a technology, the A1C reduction is even more. And sometimes the technology is cheap or even available free of cost.
Free of cost, yes. Exactly. Yeah. So what are the most essential and cost-effective technology that every doctor can use in their day-to-day practice?
Dr. Ashwin David is the lead and head in one of the Jothydev Diabetes Research Centers in Kerala, and I know that you are using technology in your daily practice. You see a lot of patients daily, and you could have yourself experienced seeing patients who are affordable versus not affordable. Exactly. So when we are discussing about technology, the number one use of technology in diabetes, I will probably recommend in monitoring glucose, because that is the most important procedure or step which will 100% result in better control of diabetes. But it all depends upon how you choose the best for your patient, and that is where you have to use your own clinical judgment, your common sense in identifying the patient who will have the optimal benefit from using a particular glucose sensing technology, since multiple such technologies are now available in India. And this is probably defined as personalized diabetes care.
Exactly. Thank you, sir. I was going to ask about that because
Yeah.
as we know that when you look into the day-to-day clinic, in your day-to-day practice, we have seen a lot of, we have been always discussing about all the technologies basically, like the normal daily glucose monitoring, which we are discussing. But when you look into, from the patient's point of view, maybe 10% of the patients are only, they must be using even a glucometer in our day-to-day practice. So how can you change that from a normal practice, like going to the lab and looking into the patients, or how can you change that to the patient, convince the patient to use the glucometers?
Dr. Ashwin David, in the beginning, in the introduction, you explained about using urine glucose monitoring for almost 100 years. And then it was found that it is not sufficient. So in modern medicine, when you improve, then you will try to improve further. You will go for a first class and then a distinction and so on. So likewise, you are trying to address the gaps, you are trying to address the existing residual gap in diabetes. And that is where we have found that urine glucose monitoring cannot bring better outcomes beyond a particular level. Of course, at those times it was the best. So I will say that what is the best technology is the technology which is available at the moment. That is the best for our patient. So now we have the glucose meters, and I will make a subtle change in the term that you have used. It is not 10%, it is not even 2%. Using glucose meters.
Exactly. That's what it is.
Dr. Ashwin David has been optimistic because in your practice, I know it is more than 90%. But overall in India, it is not even 2%. And the reason is glucometers could be painful and it is cumbersome. And that is where the connected glucose meters can make a difference. The connected glucose meters available in India, such as One Touch Vario, the My Sugar Health app available along with AccuCheck instant glucose meters. These, I will say that they are extremely good, and these come at no extra cost, but the value is much more for the patient. You require only an ordinary smartphone. All the smartphones have Bluetooth connectivity, and then you connect with the glucometer, and your glucometer values will get transferred to the mobile health application, and the mHealth application will have, for example, in My Sugar, there are seamless possibilities. You can log in any data, you can connect with other health apps in the phone. So if you are using it properly for a structured glucose monitoring, it will also provide you with multiple reminders. Then it can make a difference in the A1C by more than 0.5 to 0.7%, which is clinically and statistically highly significant. Because we know that even 0.2% A1C in the drug trials is considered significant. So imagine a situation where a connected glucose meter can make a difference of more than 0.5 to 0.7%. And from Jothydev also, we have multiple research publications where Dr. Ashwin David is also part of, where we have proven that when you are using a connected glucose meter, over a period of 3 to 4 months, there is a sudden and a robust difference in the overall outcomes in diabetes.
Yes, sir. Yeah. Thank you, sir. So another question is that when you are going to use the glucometers, what happens is that you can maybe take 4 readings or 6 readings. That too or not going to happen on a day-to-day practice. So what is the importance of continuous glucose monitoring in the day-to-day practice?
I think this is very important. In technology and in modern medicine, the beauty is it is dynamic. Unlike traditional medicine, it is not static. So when only traditional medicines were available for treating our illnesses, maybe 100 years ago, 200 years ago, until 150 years ago, the average lifespan of a human being anywhere in the world used to be around 26 to 27 years. That is a fact, which nobody would like to recollect now. And in modern medicine, it went on increasing from 25 to 30 to 35 to 40 to 50 to 60 to 70. And now, with continuous glucose monitoring, we are successful in further improving the lifespan of people with diabetes, and that too retaining the quality of life of those individuals. So in Continuous glucose monitoring, it is not just the matter of not pricking the fingertips, but getting lot of results once in every minute or once in every 5 minutes. And ultimately, the big data analysis has been made simplified with the new softwares, and the doctor is now capable of making a lot of improvements, and this was once thought probably never been possible. So now it is possible. Now it is possible for changing the insulin regimen, for modifying the dosages of medications. I think the most important change the CDM has made is the empowerment of patients in recognizing which diet is good or bad for them, which sort of an exercise and what duration of exercise is the best for them. And if sleep or exercise or diet or a dosage of modification of a drug is inadequate, suddenly it will be reflected on CGM, which will never be reflected on a usual glucose monitoring. So I will just give an example of a picture of both of us sitting together compared to this video.
Okay.
So CGM is actually a video of our glucose pattern where an expert doctor like you, I know that you are a very brilliant user of CGM. So we have maybe more than 2000 or 3000 patients we have CGM continuously, and that has made a difference in your practice. Am I not right? Because CGM
Exactly.
has got made a difference in your practice, and young doctors like you, after starting using a CGM like technology, it is similar to using a smartphone. And I'm sure that doctors like Ashwin David, you cannot survive without a smartphone. For not even a 1 hour, you cannot survive.
Not even 1 hour, it's possible.
So, but the only barrier probably with the CGM could be the cost, which is probably preventing all of us from using it in all the patients. So that is why we have to again customize and personalize not only on CGM but also on the frequency of use of CGM.
Thank you, sir. So, now I think the era is changing from self-monitoring of blood glucose to self-management of blood sugar, basically with the use of these technologies and continuous glucose monitoring, so they can manage with their diet. Even a subtle change in diet can bring greater impact on the HbA1c and glycemic fluctuations and all.
Brilliant. I think that terminology that you have used is excellent.
Self-management of blood glucose.
Patients themselves are empowered, and we are helping the patients know more about their diabetes. So that doesn't mean that they need not consult a doctor, but equally important will be the lab investigations. Equally important will be the physical visits to the hospital. So in your practice, how frequently you will advise CGM in your patients with type 2 diabetes?
So I usually try to advise CGM for all the patients possibly, because my next question is going to be regarding that. But in patients who doesn't have we will fix an HbA1c and that is not going to attain despite changing the medication, advising diet, exercise, that in those patients we should advise on a continuous glucose monitoring. And for type 1 patients, at least if they are not able to monitor on a continuous basis, at least once in 3 months if they can monitor, that will be good and enough. And we have got some patients who have been having GDM where we were advising on continuous glucose monitoring, and that has given brilliant effect on.
I think the recommendations we can update. So the 2024 the American Diabetes Association, unlike in the previous years, as you said, they have been very categorical in endorsing CGM in diabetes and pregnancy. So earlier, the evidence used to be less in DDM or in diabetes and pregnancy, but now we have sufficient evidence to continuously use in pregnancy. And in type 1, globally, everywhere or all over the world, the CGM is advised continuously. But as you said, for us, it is not possible. But even people who are having a low resources, they are somehow manipulating the existing devices and using it continuously, though it is a secret. And in type 2 diabetes, there is a South Asian guideline. And in the South Asian guideline, where I am also part of it, what we have recommended is, if diabetes is well under control, and if the A1C is, even if it is less than 6.5 or 6, the CGM for 14 days is advised at least once in every 6 months. And this is for the reasons that we have already discussed, including making sure that the patients are not having hyperglycemia, making sure that the 1 hour or half an hour after food is having undesirable hyperglycemia, and many other reasons. And for a patients with undesirable time below range, if it is more than 4% or more than 5%, then you have to repeat it, customize it, and that can be once in every 3 months or once in every 2 months. But in the South Asian recommendations published in a reputed journal, authors from different countries, including us, we have made a statement that in a non-reimbursable market, such as in Asia, where the patients are spending from out of pocket, then the doctors have we have justified in recommending it once in every 3 months or once in every 2 months, but we can decide on, depending upon the affordability and the eligibility, we can decide on the frequency. And if it cannot be done, as in many scenarios, we need not do at all. But remember, it is cost effective.
Yes, sir. So basically, it should not be a stress for the patient, but
Absolutely.
it should be cost effective for the patient.
If it is a stress for the patient, then the glucose will go up.
So I think that justifies the use of continuous glucose monitoring in the day-to-day practice. So another question, sir, what are the factors influencing the success and failure of these newer technologies in the day-to-day practice?
I think that is an excellent question. There are many factors which will decide on the success, and there are multiple factors which will decide on a failure. Success is when you are using it on the right patient at the right time. For example, continuous glucose monitoring is extremely useful in early stages of diabetes, including in pre-diabetes. So if you are using it in a brilliant patient with pre-diabetes, he will never develop diabetes. So it is cost effective. And when you are using it in patients on insulin or on only oral drugs, then the indications are different. So you need to explain the merits. But the biggest barrier I now witness is the doctor need to be convinced. So whether you are a young or a old doctor, the prescriber should be completely convinced that this technology or a continuous glucose monitoring or a continuous glucose meter will bring benefits for the patient. And the biggest barrier, I will say, the reasons for failure in using the technology is the doctor not having sufficient time or sufficient knowledge to share with the patient. They need to have sufficient knowledge to discuss with the patient. And they need to have an extra 5 or 10 minutes to discuss with the patient and with their relatives. And that can make a difference. And another reason for failure is when they come with the results, or when there is an option for remote monitoring, for example with a connected glucose monitor or with a continuous glucose monitoring device, you have the option for remote monitoring as well as when the patient is coming back with the report or when you are collecting the report. Again, you need to explain. You need to make them understand why you have used this technology and how you are going to use the results for changing from a basal insulin to a basal bolus or a premix, or introducing a basal insulin on top of existing oral therapies, or introducing a GLP-1, or changing the exercise timing or regimen. I am just citing some examples.
Okay,
so
sir.
they should feel as if the CGM has been extremely beneficial in bringing a change for them, or the connected glucose meter, whatever. So these steps are extremely important. For the extra time and money they are spending, we also need to spend some extra time in making them believe or making them understand this is only for them and this is a life-saving technology and not aimed at immediate benefit but for long-term better outcomes.
Thank you, sir. I think we have spent so much of time with you. Thank you so much. I think so the 4 pillars in the management of diabetes will be medication, exercise, diet, and follow-up. And I think now that newer technologies are becoming a backbone in the follow-up. And as sir correctly mentioned, for self-management of diabetes, the patient should, the healthcare profession has to spend so much of time with the patient, at least maybe 5 or 10 minutes in correctly explaining why these newer technologies are needed for the patient to get a better outcome. I think that will be more beneficial for the patient.
Thank you.
Thank you, sir. Thank you for your valuable time. Thank you, D-Genius, for giving us this opportunity. Thank you so much.
And thanks to all the friends at D-Genius for giving me also this opportunity. Thank you very much, Dr. Ashwin David. Thank you.